My name is Thomas Ciulla, and I'm a retina specialist and clinical researcher interested in angiogenesis. Today I'm going to present longer-term anti-VEGF outcomes in neovascular AMD, diabetic macular edema, and retinal vein occlusion-associated macular edema. My commercial disclosures are shown on this slide. I have previously presented and published on one-year real-world outcomes in neovascular AMD, diabetic macular edema, and retinal vein occlusion-associated macular edema. We have noted the following. Real-world patients experience only a modest gain in visual acuity, with injection frequency playing a large role in visual acuity outcomes. In addition, better baseline visual acuity increases the risk of visual acuity loss. Also, in clinical practice, real-world RVO-related macular edema patients experience greater one-year visual gain than patients with AMD and DME, but exhibit a larger gap in visual gain when compared to respective randomized controlled trials. These bar charts summarize the results of some of these studies. Of note, real-world RVO-related macular edema patients improved by 7 to 8 letters at 1 year, DME patients improved by 4 letters at 1 year, and neovascular AMD patients improved by only 1 letter at 1 year. All generally received fewer intravitreal anti-VEGF injections in clinical practice compared to respective randomized control registration trials, and these real-world patients generally underperformed meaningfully. Across both the real-world studies and randomized control studies, bevacizumab, ranibizumab, and aflibercept performed similarly. In our prior studies and in the current study, we assessed real-world experience with anti-VEGF therapy using the Vestrum Health Retina database. This database includes the electronic healthcare records of hundreds of U.S. retina physicians with more than 800,000 unique patients. In this current study, longer-term outcomes were assessed, with inclusion criteria involving a diagnosis of treatment-naive neovascular AMD, DME, or RVO-related macular edema, with treatment commencing between 2014 and 2019 and at least 1 year of follow-up. Patients were divided by disorder and cohort based on the number of years of follow-up out to 5 years. There were approximately 130,000 patient eyes. In AMD, approximately 2/3 were female, and in DME and RVO, approximately half were female. As expected, AMD patients were oldest, in their 70s, with DME patients being the youngest in their early 60s and RVO patients in their early 70s. Mean baseline visual acuity was between 54 and 63 letters, Snellen equivalent between 2080 and 2050 for all disorders except CRVO, which showed the worst baseline visual acuity at approximately 45 letters, or 20/125 Snellen equivalent. With respect to top-line results, 1-year results were similar to those previously reported, with 3- and 5-year results showing worse outcomes than 1-year results as expected. Overall, at 1 year, real-world patients experienced only a modest gain in visual acuity. Also, real-world RVO-related macular edema patients experienced greater 1-year visual gain than patients with AMD and DME, but exhibit a larger gap in visual gain when compared to respective randomized controlled trials. Across all disorders, 3- and 5-year data showed worse outcomes compared to 1-year outcomes as expected. This slide shows outcomes by disorder and by cohort, with BRVO patients performing best, followed by CRVO patients and then DME patients. AMD patients generally lost visual acuity between 3 and 4 years on average. This slide shows injection frequency versus visual acuity outcomes for the 3-year vein occlusion cohorts and the 5-year cohorts of AMD and DME patients. Overall, across disorders, more frequent anti-VEGF injection yielded better outcomes. Of note, AMD patients treated with fewer than 40 injections over 5 years lost visual acuity on average. Within disorders, patients generally receive similar numbers of injections regardless of baseline visual acuity. However, those with worse baseline visual acuity showed the largest mean change in visual acuity over 3 years, while those with the best baseline visual acuity were at the greatest risk of vision loss. In summary, real-world RVO, DME, and AMD patients show worse 3 and 5 year anti-VEGF outcomes compared to 1 year outcomes as expected. BRVO patients perform best, followed by CRVO patients and then DME patients. AMD patients perform worse, generally losing visual acuity between 3 and 4 years. As an aside, I want to highlight that these data sets probably overestimate the outcomes, as patients who drop out from clinical follow-up are not included. Overall, across disorders, more frequent anti-VEGF injection yielded better outcomes. Of note, AMD patients who were treated with fewer than 40 injections over 5 years lost visual acuity on average, highlighting the very significant long-term treatment burden with current agents. Finally, across all disorders, those with worse baseline visual acuity showed the largest mean change in visual acuity gain over 3 years. Importantly, those with the best baseline visual acuity were at the greatest risk of vision loss. In conclusion, current therapies are associated with significant treatment burden for patients, families, and the healthcare system. There remains significant unmet need for more effective therapy with durability to address treatment burden. Thank you very much for your attention.